This video details performance of umbilical venous and arterial catheters in neonates, the indications of which are for emergency vascular access, delivery of meds, fluids, and blood, parenteral nutrition, and obtaining laboratory studies. Contraindications include malformations that distort the vascular anatomy, infection, omphalitis or peritonitis, necrotizing enterocolitis, or evidence of vascular compromise to the lower extremities. Complications of umbilical vessel catheterization include infection and bacterial colonization of the catheter, air embolus, vessel perforation or aneurysm formation, pericardial tamponade or perforation, generally with UVC, perforation of the peritoneum or intra-abdominal organ, systemic and or portal hypertension, hepatic necrosis from placement of a UVC into a hepatic vein, ischemia of the legs, buttocks, bowel, or kidney, or arrhythmias. Institution-specific and commercial umbilical vessel catheterization kits are available. Have all materials ready before beginning. Necessary equipment includes a radiant warmer and light source, cardiac monitors and pulse oximetry, sterile drapes, mask, gown, and gloves, povidone iodine solution, gauze pads, and adhesive tape. In addition, you will need a scalpel, number 11 or 15 blade, curved hemostats and straight forceps, iris scissors, a needle holder and 3/0 or 4/0 silk suture, an umbilical catheter, linen umbilical tape, a 10 ml syringe filled with normal saline with or without heparin, and IV tubing. Remember that placing an umbilical line is a sterile procedure. Clinicians should wear sterile surgical gowns, gloves, caps, mask, and goggles. A normal umbilical cord will have 3 vessels, 1 vein, and 2 arteries. Let's begin by reviewing placement of an umbilical venous catheter. The infant should be positioned in a supine frog leg position. Restrain the limbs if necessary. Next, scrub the neonate's abdomen and remaining umbilical cord with a bactericidal solution. Assure that you prep from the xiphoid process to the pubic symphysis. This should be done 3 times. In this example, a sterile fenestrated drape is then placed over the umbilical area. After the patient has been draped, tie umbilical tape with a surgeon's knot at the base of the umbilical cord in order to provide hemostasis and to serve as an anchor after line placement. Grasp the cord with your fingers or forceps and cut transversely with the scalpel. This will allow you to identify the umbilical vessels. Using a dilator, which is often found in the insertion tray, gently dilate the lumen of the vein. Next, grasp the cut edge of the cord with forceps or a curved hemostat. Then, insert the tip of a previously heparin-flushed catheter into the vein lumen. A 2.5 French catheter is appropriate for neonates less than 800 to 1,000 grams. A 3.5 French catheter should be used in preterm infants greater than 1,000 grams, and a 5 French catheter is effective for term infants. Many institutions have internal guidelines as to how far the tip of an umbilical venous catheter is placed. In general, you want to assure that you are not meeting resistance when you gently thread the catheter into the umbilical vein. The overall goal of UVC placement is to thread the catheter into the inferior vena cava, just above the diaphragm, at the level of the IVC right atrial junction. Exact insertion depth can be difficult to determine. One method entails measuring the distance from the shoulder to the umbilicus and then estimating the distance the tip should be inserted on a nomogram. Other methods entail use of mathematical formulas, shown here. If resistance during insertion is encountered at 5 to 10 centimeters, this may indicate passage into a portal vein, which increases the risk of hepatic necrosis. Once you have inserted the catheter, flush each of the lumens with saline or heparinized saline. Next, obtain an X-ray to confirm proper placement. Finally, suture the catheter in place. You may elect to use a purse string suture around the cord. Then, wrapping the suture around the line and securing with square knots just above the umbilical cord and at a distance 2 to 4 centimeters from the end of the cord. Finally, remove the umbilical tape and place a stabilizing dressing on the patient's skin. The procedure for placing an umbilical artery catheter is similar to that of a UVC. We will review the differences with regard to depth and position of placement. In general, you can use a 3.5 to 4 French catheter in infants less than 2 kilograms and a 5 French catheter in infants greater than 2 kilograms. Resistance during insertion is usually felt at 2 points. The umbilical artery first courses towards the feet. Therefore, initially, tension should be placed on the cord in a cephalad direction in order to pass the line inferiorly. Greater resistance will be felt when the umbilical artery meets the internal iliac artery at 5 to 6 centimeters. Applying a gentle twisting motion may allow you to overcome this resistance. 2 insertion depths for UAC placement are generally accepted. Neither has been proven to be superior, and practices may vary by institution. A UAC placed above the diaphragm is between thoracic vertebra 6 through 9. It is located in the thoracic aorta, between the ductus arteriosus and the origin of the celiac axis. Catheters placed below the diaphragm, otherwise known as a low-lying UAC, sit between L3 and L5 in the abdominal aorta, specifically between the inferior mesenteric artery and the bifurcation into the iliacs. As always, before use, confirm placement with radiographs.